Okay, very good. Okay, perhaps we'll get started then. Hello, everybody. Welcome to St. Paul's Hospital Ground Rounds on May 11th, May 18th. We are coming from St. Paul's, which I would like to acknowledge is the traditional, ancestral, and unceded territory of the Coast Salish peoples, including the Squamish, Tsleil-Waututh, and Musqueam nations. And we're very grateful for their stewardship of these lands. Today, it's my absolute pleasure to introduce Dr. Heather Leitch, who is a hematologist and a clinical professor in the Department of Medicine at the University of British Columbia. Dr. Leitch's clinical and research interests include transfusional iron overload in acquired anemias, such as myelodysplastic syndrome, and she also has a long-standing interest in lymphoproliferative and other blood disorders in patients with HIV infection. She is the Director of Hematology Oncology Research at St. Paul's Hospital. She is a reviewer for multiple scientific papers and several medical journals, and she's also an active member of the UBC Department of Medicine Equity and Research Advisory Committee. Her presentation today is on recent advances in myelodysplastic syndrome, prognosis, and management. With further ado, Dr. Leitch, welcome. Thank you for this presentation.
Thanks very much. So I'm going to speak for just a minute at the end on myeloid disorders in general, but first I wanted to talk to you about sort of what's new in MDS. These are my disclosures. And so this is the agenda, just an introduction, the updated classification systems, prognostic scores, show you an online algorithm to assist in diagnosis and workup and management, some of the treatment options, iron overload, and just a bit on myeloid disorders at the end, and then a summary. So MDS are a group of clonal hematopoietic stem cell disorders characterized by ineffective hematopoiesis and an increased risk of developing AML. And the IPSS and newer scores predict survival and risk of AML transformation. So just to show you a few blood smears, this is a normal blood smear, and normal lymphocytes, the nucleus should be about the size of a red blood cell, and here's a neutrophil, which is nice and granulated, and its nuclear lobes look nice. This one's not so normal. So first of all, the red blood cells are kind of all sizes and shapes. This is a hypergranular neutrophil, and this is a hypogranular neutrophil with big lobes with a little strand between them. It kind of looks like, a guy with great big shades from the 70s. And this is what's called a Pelger-Hewitt cell. So MDS, the blood counts are decreased and the cell morphology is abnormal, as opposed to MPN, where the blood counts are increased and the cell morphology is normal. This is a bone marrow aspirate. This is a normal one. And so you can see a number of, different cell types. And here's a nice orderly looking megakaryocyte. This is a normal bone marrow biopsy. And so you can see, the fat cells and the cellularity is appropriate for this person's age. And so this is an ET aspirate. And so you can see these big megakaryocytes, which tend to cluster together and have these crazy lobes. And that is behind my viewer. So just give me a moment so I can see. Okay, so this is myelofibrosis. It's just fibrotic tissue. Here's a biopsy. That's a normal biopsy. This is just a higher power view of a normal biopsy. ET, again, the cellularity is increased, and you see lots of megakaryocytes as opposed to just a couple in the normal biopsy. And myelofibrosis, you can see the sort of scar tissue here. So these are some dysplastic features. So we talked about hyper and hypogranulation. This one has crazy number of lobes to the nucleus and what's called nuclear budding. And then this is an immature red blood cell which still has its nucleus. And this is an iron stain. And you see that the iron is staining around the nucleus. This is what we call a ring sideroblast. And so that is a dysplastic finding. This is a myeloid blast. We obviously don't want to see these in MDS because that can portend transformation. This is an outer rod. If you see an outer rod, then it's AML. You can have AML without outer rods, but look how huge this is compared to the red blood cell. So it's just huge, and it's a very stiff cell. You can see there's vacuolation in the cytoplasm. There's lots of nucleoli, so it's very active. I'm not sure why I had a second picture of that same blast. This is the 5q minus syndrome in MDS. This has a deletion of the long arm of chromosome 5 as a sole cytogenetic abnormality. Unlike everything else in medicine, there's a female predominance. It has an indolent course, favorable prognosis. AML transformation is only around 15%, and median survival is long. So this is a normal marrow aspirate, and I've tried to put this at similar magnification to an aspirate from del5q. And what the arrows are pointing to are what are called micromegakaryocytes, which is my favorite word in hematology. It literally means little big cells. So predisposing factors unknown in the majority: older age, male gender, secondary to certain classes of chemotherapy, ionizing radiation for other cancers, and possibly some chemicals and immunosuppressants. This is the age-related incidence of virtually every hematologic malignancy. I actually borrowed this from CLL. And so what you can see is that the median age of the baby boomers is around here. And it was around here 10 years ago. So, we've more than doubled the incidence, and the prevalence is also increasing as we get better at keeping patients alive longer. So in 84% of low-risk patients, the cause of death is the MDS itself. So it's a big deal. And treatment decisions are based on things such as disease-related factors, cytopenias, number of blasts, and the karyotype, which feed into the risk scores, but also, especially in Canada with our geography, patient-related factors such as distance from the treatment center, as well as age and comorbidities. So, one of the reasons MDS is confusing is that the classifications keep changing. So this is kind of milestones in making sense of MDS variability. So the first classification in 1982 was the FAB, French, American, British, which was based on morphology and spearheaded by Dr. John Bennett, who was at the International Society of MDS meeting 2 weeks ago at age 90. Still working, still chairing sessions, getting up, making brilliant comments. So he's kind of the epitome of FAB. We next had the International Prognostic Scoring System, which incorporated cytogenetic changes, the WHO 2001, which refined morphology, the WHO-based prognostic scoring system, which took into account transfusion dependence, which affects survival, as I'll tell you. MD Anderson has one of their own of everything. Then there's the WHO 2008, the IPSS revised, cytogenetic scoring system, the WHO 2016, the MDS CAN score, which I'll show you. And we now have the WHO 2022 as well as the International Consensus Classification. And in the future, we will incorporate things such as microRNAs, somatic mutations, which in this case, the future is now, as I'll show you, epigenetic changes, circular RNA, inflammasomes, and machine learning models. So therapeutic objectives in MDS are to reduce red cell transfusion requirements and improve quality of life, and to hopefully extend survival and delay AML progression and alter the disease's natural history. So I think that these latter two we have done somewhat in higher risk MDS, although that's not, so certain in lower risk at this point. So this is a long list of potential treatment options, but in reality, for the majority of patients, the options are much more limited. Erythropoiesis stimulating agents such as EPO and DARBO, supportive care, red cell transfusions plus or minus iron chelation, and for higher risk MDS, hypomethylating agents, as I'll show you, with or without other agents, and most patients are too old for stem cell transplantation. So that's not really a lot of treatment options. This is a slide that I poached from one of the leaders in the field, Uwe Platzbecker from Germany, in 2019, showing the cellular pathways that new treatments are trying to target. And in 2022, these are the pathways that have not worked out. So it's been a while since we've had a new medication in MDS. Classification systems. This is taken from our online algorithm, and it just basically shows you the WHO classification system with links to other topics, and I'll talk about that more in a minute. We now have the WHO 2022, and I won't dwell on the details because we really leave this to the hematopathologist. But just to point out, it's becoming more molecular somatic mutation based. So what we used to call MDS with ring sideroblasts, almost all of them have the SF3B1 mutation, which is a spliceosome mutation. And TP53 is recognized to be a very poor prognostic factor. And they're changing the definitions of how many blasts means what as well. This is the overlap syndromes, MDS/MPN. And these, this is the international consensus classification. So it's been a bit for the pathologists because there's now two classification systems and they're not quite sure which ones to use in which setting, although we have recommendations from the brilliant Dr. John Bennett. And then there are changes to the MDS-MPN overlap syndromes as well. The relationship between the three scores is relatively complicated. So WHO 2017, 2022, and the ICC. And as if that's not enough, we have another page of that. So prognostic scores. This is the International Prognostic Scoring System, which was based on bone marrow blast percent, karyotype, and cytopenias. And this is literally from up to date. I copied it from there. So the IPSS-R has the same prognostic factors, although it has more categories. It kind of refines things by cytogenetic category, more blast percentages, more cutoffs for hemoglobin, platelets, and neutrophil count. But the big news is the molecular IPSS, which was just introduced less than 1 year ago. It was presented at the EHA meeting in June 2022. And so what they did was they had what they called a discovery cohort of 3,000 patients, and then a validation cohort of just over 700. These are the mutations that you typically see in MDS, and they identified 48 gene mutations in more than 1% of patients. 94% of patients had at least one gene mutation with a median of 4 per patient and a range up to 20. And they looked at association between the different mutations and clinical endpoints, leukemia-free survival, overall survival, and AML transformation, and adjusted for confounding factors, age, sex, MDS type, primary versus therapy, and so on, and found there were 14, 16, and 15 genes respectively associated with adverse outcomes. So they maintained the 5 IPSS-R cytogenetic categories and then looked at gene mutations as binary variables except TP53 because the biallelic TP53 is very bad, whereas monoallelic is not so bad. And SF3B1 subsets. SF3B1 is the only mutation that has a favorable prognostic implication, but it's modified by its pattern of co-mutations. And so then they developed this model, which is this very simple looking formula, which translates into this curve and just divided it into 6 categories: very low, low, moderate, high, very high, and very high. So, in the IPSS-R, kind of the cutoff between lower and higher risk was halfway through the intermediate category, which was awkward. Now we have a cleaner division. And you can see that the categories separate by leukemia-free and overall survival. So they found that there was a 5-point increase in concordance index from the IPSS-R to the IPSS-M across all endpoints, and nearly half of patients were restratified with 7% by more than one strata. And here is the publication in NEJM Evidence. So this is what the calculator looks like. So you enter the usual prognostic factors and then the cytogenetic category, And then it comes up with all these mutations, and you click on mutated versus non-mutated, and it comes up with a score for you. So that is very exciting. I was just attending the sessions on familial inherited mutations at the ISMDS meeting 2 weeks ago, where they did find that there was prognostic significance to 4 different mutations, and actually none of those 4 are actually included in the IPSSM. So I think there will be revisions going forward, as if we haven't had enough revisions already. Also, a very fascinating presentation at the EHA last June was epigenetics. And so we know that hypermethylation in MDS, hypermethylation in any condition of the promoters at CPG islands silences genes. And this investigator actually showed that was quite significant in MDS, as I'll show you. So this is methylated cytosine and compared to cytosine. And so here we have a normal cell, and you have certain methyl groups, and in a cancer cell, you get lots more methylation. It messes things up. This is the mutations in the epigenetic modifier genes in MDS. So it's the same mutations I showed you, but the arrows indicate epigenetic modifiers. And this is the DNA methylation pathway. And the point of this slide is for me that iron is a cofactor for DNA methylation. So I've made these bigger so you can read them, but I'm not going to go through them. But we do see aberrant methylation in key biological pathways. And I think you can appreciate that these are, important pathways. And so very interesting work, and don't ask me to explain these graphs, but basically they found that there was a difference in the pattern of methylation at diagnosis in higher risk MDS, which distinguishes people who are going to respond to a hypomethylating agent such as azacitidine versus non-responders. So how cool would it be if we had a test at diagnosis where you could actually tell who is going to respond to the medications that we have? They found that the ROC curve of standard cytogenetic analysis is 0.65, increased to 0.85 in using the promoter hypermethylation. And if you add gene expression profiling, it increases to 0.88, whereas GEP alone was not significant. So I think that this is very exciting and going to be even more exciting in the future. So epigenetic modifier genes are frequently mutated. Genome-wide methylation studies uncover previously unrecognized hypomethylation. Aberrant DNA methylation targets, key biological pathways, captures clinically relevant information, and the differences can be harnessed for the development of epigenetic biomarkers, and that can be further strengthened by integrating gene expression profiling. So will we have this anytime soon in BC? I'm not sure. I asked that question of our person in the molecular lab, and basically the answer was money. So we'll see. Turning to the MDS scan, I've kind of taken you off my view, so I can't see if anyone has any questions, but feel free to, if you want clarification as we go along, but happy to take questions at the end as well. So the MDS scan is a national registry throughout Canada of MDS patients. And it's a study of quality of life in MDS patients. And so what it consists of is every 6 months, the patients fill out questionnaires on their quality of life. And every year they undergo small tests of physical function. How fast can they walk 4 meters? How fast can they stand up and sit down 10 times? And what's their hand grip strength? So many of our patients like to participate in this because they feel like they're contributing to knowledge, which they are, but they feel like they're not a guinea pig because they're not taking an investigational agent. So it was started in 2007 at Sunnybrook in Toronto, went national in 2012. And that's just what I said. So we prospectively collect data on clinical frailty score, Charlson Comorbidity Index, the MDS-specific comorbidity index, and the Lawton-Brody disability score, which becomes important later. So this is something that was published in 2016. And what was found in a multivariable analysis was what what was significant for overall survival was the IPSSR, the frailty score, and the Charlson Comorbidity Index. And so a weight was given to each of these variables and came up with a final sort of low, intermediate, high risk model. And you can see quite a separation of the overall survival curves. So, the importance of this, it's the first and still the only prognostic score that takes into account patient-related variables. So we all know frail patients are going to do worse, but this is something that starts to quantify them. And so we're now talking about, incorporating this into the IPSS molecular as well. Okay, MDS ClearPath, if there's any residents in the audience, they may have heard this from me, but I wanted the staff to know also that we have an online algorithm, which is to assist the workup, diagnosis, and management of MDS. Of course, here in downtown Vancouver, you have us, but in some of the outlying areas, not so easy access to hematology, and also not all hematologists are focused on MDS. So this has been live since 2013. However, we did do a 2022 update, which I'll point out to you. So you can just type MDS ClearPath into your browser and it should come right up. The iPad app did expire and they're working on updating it. It should be available soon through the website or through the Apple App Store for free. And you can see that this is available also in French. And I know Anna wants to practice her French, so that will be handy. So there's two more modes. There's the overall algorithm, and there's what we call the treatment wizard, which leads the user through a series of questions, particularly the specific patient's clinical status, leading to a treatment recommendation, which I'll show you. So just a case-based approach. This is a 74-year-old woman referred with anemia, and she's tired and short of breath on exertion. Her hemoglobin's 95. The MCV is increased, so it's a macrocytic anemia. Neutrophils are 1.7, platelets 84, and she has oligomacrocytes and hypogranular newts. So those are dysplastic changes. So we do some things to rule things in, rule things out. And the first question is what further investigations are indicated. So if you go to the MDS ClearPath, the first screen is, have you diagnosed your patient with MDS? And this button says, please start here if you have yet to confirm your MDS diagnosis. And from here, you can go to the treatment wizard or the overall algorithm. There's also links to the prognostic calculator, which I'll show you, and references. So if we press on please start here, it takes us to 3 steps to confirm a diagnosis of MDS. And so the first is perform an initial workup for MDS. We click on that. It gives us an information panel, which tells us what things to do to roll things in and roll things out, including more recently sending a sample for molecular testing. And all these chevrons across the top are links to other topics. So we can go here to close the information panel. And so this is giving some indications for molecular testing and what some of the genes do that we find somatic mutations in. The second step is classify the patient based on the WHO classification, which I showed you earlier in the presentation. And step 3 is stratify the patient to lower or higher risk using any of the classical scores. But we've also added the comprehensive, this should be the MDS CAN score, but this is the frailty index. So looks like I'm missing the IPSS-M on this picture, so sorry about that. There is a link to the IPSM calculator. So going back to the patient, she has a bone marrow biopsy that shows trilineage dysplasia, 2% blasts, 7% ring sideroblasts. The WHO classification was refractory cytopenia with multilineage dysplasia. The previous one, now MDS with multilineage dysplasia, and something else in the most recent one. Cytogenetics are a deletion of the long arm of chromosome 20, which is a good risk karyotype in both the IPSS and the IPSSR. Serum EPO is 284, which becomes important later. So what's her IPSS category? And we actually still use the IPSS because that's what most of the clinical trials are based on, although we are, taking into account information from the newer scores as well. So this gives you a list of the scores, and you can click on it for more information. And so this is the IPSS and something like you would see in UpToDate. It takes you to the calculator. You can also go to the survival curves. And so the calculator is a series of drop-down menus where you can enter the patient's information. And so with the first few things, up comes the IPSSR, which is very low risk, then the IPSS intermediate 1, which is lower risk, and then the other scores. And then you can reset it. And the people who have done the online thing are working on incorporating the IPSSM calculator, which is much more complicated, into this prognostic calculator. So this is the survival curves. And so then it takes us to this panel, which says once the MDS diagnosis is confirmed, to HLA type if they're a transplant candidate, screen for PNH when appropriate, give information to patients and caregivers, and also gives advice on when to refer to a center with expertise. And then we can click on this little finish over here, and it takes us back to the treatment wizard. So the first step, does your patient have lower risk or higher risk MDS? So she has lower risk. Have we assessed for allogeneic stem cell transplant in all low-risk patients? This talks about eligibility for transplant with links to things like efficacy, safety, donor availability, and so on. She's not young enough for a transplant, so it's not an option. Is she symptomatic? Yes, she is. Does she have symptomatic anemia, neutropenia, or thrombocytopenia? She has symptomatic anemia. This gives information on, transfusion thresholds and so on. Does she have a Delphi Q? This is important because if she does, they respond to lenalidomide and can become transfusion independent for quite a while. She does not have this, so we say no. Is she a candidate for immunosuppressive therapy? What's meant by this is anti-thymocyte globulin plus cyclosporin plus high doses of steroids. I actually find that this is really quite intensive for most of our patients, and it doesn't work very well. So we'll say no, because it's kind of the same intensity as acute leukemia therapy. So the treatment recommendation is for an erythropoiesis stimulating agent for all patients with symptomatic anemia with an EPO level less than 500. The new cutoff is less than 200. And so this gives information on ESAs. There's my 200. And so this talks about probabilities of response to ESAs, gives the prognostic factors. Sorry about that. We get a lot of sirens here. And so this gives the dosing information. So different than you see in renal dosing, what to increase to after how many weeks for lack of response. And there's links to safety, efficacy, provincial reimbursement, which I'll show you, and some other, I don't know what's going on, sorry. Okay, so this is response evaluation. So, of course, she wants to avoid transfusions because everybody wants to. They don't feel well leading up to their transfusion. They have to come in for the cross match. They have to pay $30 for parking. They have to run the gauntlet of the people with tents outside. So she started on EPO, 40,000 units per week. And after 8 weeks, her hemoglobin is just 88. So it's increased to 60,000 units. And she becomes transfusion independent and her symptoms are better. So this is the provincial reimbursement, which when you're hooked up to the internet, which I'm not, you can actually click on the province of interest and it will take you to the reimbursement page for that province for that medication. So now she's 75 and her count drops substantially. She has her peak bone marrow, which shows her blasts are up to 14%. She's acquired a poor prognosis cytogenetic abnormality. So these are a bit out of order. Sorry about that. This is response criteria and loss of response. And these indicate disease progression. So potential indicators, worsening cytopenias, new cytopenias, appearance of blasts, rising LDH, and so on. And so we go back to the prognostic calculator, and she's high to very high risk. And so is she a stem cell transplant for higher risk MDS? No. Is she a candidate for azacitidine? Yes, she is. So this is the AZA 001 study. And what it showed, and so this was published in 2009, so it's over a decade ago. What it showed, it randomized patients between azacitidine conventional care regimens, and it actually showed an improvement in overall survival. And it's actually the first medication in higher risk MDS to show an improvement in overall survival, even including AML chemotherapy. So it's been a big deal and has extended the life of many of our patients, and continues to be a big deal. And we would like things to add on to it so we don't eventually lose the patients. So this is the overall algorithm: lower risk, higher risk, and all the decision points. Things that are new in 2022 are response assessment criteria. We have information on MDS with RS/SF3B1. There's a new medication called luspatercept, which works well in these patients. We used to have only azacitidine, but now we have an oral form of decitabine, which is a similar agent combined with cedazuridine, which allows it to be absorbed orally. So it has information on that, and we call it, are they a hypomethylating agent candidate rather than are they an AZA candidate. This is showing the IPSS-M links. And we also have some of the acquired predisposing conditions, information on that: idiopathic cytopenia of undetermined significance, clonal hematopoiesis of indeterminate potential, clonal cytopenia, and so on. And I actually find, for my patients that I investigate with unexplained cytopenias and their bone marrow is normal and everything's normal, they seem to be much happier since we've had the word ICUS to, describe their condition rather than we can't find any reason why you should be cytopenic. So they seem to be reassured that it's a recognized thing that's kind of in the textbooks and the up-to-dates and so on. This panel talks about investigating for familial predisposing conditions. And that's really what I had to show you on the MDS ClearPath. There's a lot more information in it, but just sort of the basics. You may want to cruise through it on your own, particularly when you're investigating patients with cytopenias. So in terms of treatment, this is very quick. So regional clinical trials in lower risk MDS, I actually have a clinical trial of an erythrocyte pyruvate kinase activator to protect the cells from breakdown, open right now and enrolling at St. Paul's Hospital. I have 6 patients on this study. They're early in treatment, and hopefully we'll see some responses. It's shown good responses in thalassemia, so hopefully it will in MDS as well. There was a trial at Surrey looking at adding the BCL2 inhibitor venetoclax to azacitidine in higher risk MDS. However, it has completed enrollment, so it's closed now to enrollment. At VGH, Dr. Florian Kuchenbauer has a trial in second-line therapy for higher risk MDS, which is kind of big news because we've been nagging the pharmas for decades to do trials in second line, and coming soon, oral azacitidine. So I'm going to turn to iron overload. This is my particular interest, iron overload from transfusions in myelodysplastic syndrome. So this became kind of a big deal in 2006 when we did analysis from our patients at St. Paul's Hospital, showing that those who received iron chelation therapy for transfusional iron overload had improved survival compared to those that did not. So, that was a study, and there's been several similar studies since that was, criticized because it wasn't prospective and so has potential biases and so on. So I'll talk about that a little bit. So the MDS ClearPath talks a little bit about iron overload, but it can also take you outside the algorithm to our similar algorithm, which is all about iron. So taking a step back, it's been recognized for many years that transfusion dependence in low-risk MDS is associated with inferior overall survival. This is from the Italians. So this is how many units you need per 4 weeks, and none. 1, 2, 3, and 4. You can see a stepwise decrease in survival with a decrease in leukemia-free survival on the right. And more recently, from the European Leukemia Net MDS registry, they showed that in a low density, which they defined as less than 0.87 units per month, the survival is inferior and even worse with a high transfusion density. So we developed Canadian guidelines for the management of iron overload in MDS, which I basically did sitting at my desk on the weekends, and my colleagues helped me criticize. So these are colleagues from across the country. We call ourselves the Canadian Consortium on MDS and have many activities, including publications, and I'll tell you a little bit more about that in a few minutes. So developed an algorithm which we call the MDS Iron Road. And again, you can just put MDS Iron Road into your browser and it'll come right up. I don't know how well you can see this, but in the background is a train engine. So this was inspired by two things. The first is the song by Lightfoot, the Canadian Railroad Trilogy. But the second thing is that I can't quiz you like I do the residents, but the word for railway in Italian is ferrovia, or literally iron road. So again, it's available in English and French. This is the last spike of the CPR being driven at Craiglachie, BC, just outside Revelstoke in 1885. And I actually didn't realize this until I was doing the algorithm, but it was actually a big part of the deal that brought BC into Canadian Confederation. So it's kind of a Canadian moment. This is the overall algorithm. So low-risk MDS, information on what that means, higher-risk MDS, assess for allogeneic stem cell transplant eligibility. Are they transfusion dependent? Information on what that means. Do they have a reasonable life expectancy? Do they have documented iron overload? Information on that. If no, monitor iron status. Information on how to do that. If yes, are you able to induce transfusion independence with an MDS treatment to reduce iron overload that way? So if yes, then information on phlebotomy. If no, then information on iron chelation. And so there's lots of information on iron overload and transfusion in the usual clinical setting and also in the stem cell transplant setting. We have in the algorithm levels of evidence and grades or recommendations, future directions, and references. So like the MDS ClearPath, which has the treatment wizard, we have the overall algorithm that's something we call the IR Express, which is the step-by-step thing that takes you to a treatment decision. I've just excerpted this couple of panels. So are they eligible for therapies that induce transfusion independence? If yes, then it takes you outside the algorithm to the MDS ClearPath to talk about those therapies. If no, it takes you to information on chelation. If you click on received a therapy that can induce transfusion independence, it takes you to information on phlebotomy. There was a randomized control trial called the Telesto, looking at prospectively at patients receiving iron chelation versus not. There were problems with this trial. So, people like me who believe iron is important didn't want to randomize their patients to placebo. People who thought that MDS patients don't live long enough to get problems from iron overload didn't want to randomize their patients at all. So the study population was reduced by 2/3. It was no longer powered to detect a survival endpoint. The median age of the patients was only 60 compared to 72 at diagnosis in our usual MDS patients, and then several years to transfusion dependence. And also half of placebo patients dropped out and subsequently received chelation. But despite all these problems, you can see a separation between the curves in event-free survival. We turned to the Canadian MDS registry to see what was the deal with our patients there. So, you remember that we prospectively collected data basically on their performance status, and we found that those who received iron chelation had better survival than those that did not. The other thing that we did was we counted survival rather than from diagnosis, which is what you can do retrospectively. We counted it from onset of transfusion dependence. And then we did a bunch of matched pair analyses, removing patients with MDS subtypes or receiving treatments that were, thought to portend better or worse prognosis. And in all but one of the matched pair analyses, the survival was superior in the chelation patients. So, the people who think that MDS patients don't live long enough think that it's all about organ iron, but it's not all about organ iron. So non-transferrin bound iron is important as well. So this is meant to represent transferrin, and this is the usual saturation. Once you saturate it completely, you get non-transferrin bound iron, a subset of which is labeled plasma iron, which is redox active. So LPI can deposit in the tissues and organs, including the bone marrow, but also because the ability of iron to transfer electrons can undergo Fenton chemistry and lead to the production of reactive oxygen species, or ROS, or oxygen-free radicals, which have been shown in multiple preclinical studies, which are all talked about in the Iron Road. That's what this is taken from, which has been shown to damage lipids, proteins and nucleic acids. So I'm sure you can appreciate that that could have consequences for cells. From the EU MDS registry, they looked at labeled plasma iron, which is not hard to measure, but it's just hard to do in a clinical lab. And so they found the best survival was in patients who are transfusion independent with an undetectable LPI. The worst was transfusion dependent detectable LPI, and the other two groups had an intermediate survival. In the transplant setting, this is called the ALIVE trial. And so this is liver iron concentration by MRI. So overall survival is worse if you have a pre-transplant elevated LIC, but also if you have an elevated pre-transplant LPI. And the same was true of non-relapse mortality. So what's going on in the cells? So I've got 2 slides of the hematopoietic stem cell, and I'm going to take you back to your cell biology. So this is the usual route, iron entering, bound to transferrin into the endosome, released into the label iron pool, but also NTBI entering in an unregulated manner, expanding the label iron pool, causing the formation of reactive oxygen species. This causes a shift from glycolysis to oxidative metabolism, which causes the stem cells to exit the quiescent state and makes them prone to undergo cell senescence and exhaustion and death. There's also a loss of more than half of the full-length mitochondrial DNA, which, as you remember, doesn't have histones to protect it, which further affects respiration and results in cell death. Activates caspases, which are required for apoptosis or programmed cell death. There's also oxidative DNA damage, which results in base excision repair, double-strand breaks, and non-homologous end joining, which is error-prone, which can lead to cell cycle arrest and also progression to AML. There's oxidation of lipids, which is long-lived, and they can oxidize other macromolecules, result in cell and organelle lysis, and alter the fluidity of membranes and channels. It also shifts hematopoiesis away from CFU megakaryocyte erythroid and towards GM, which could obviously impact clinically on anemia. There wasn't enough room on one slide, so this is the same stuff happening. So we get here, ROS affecting HIF1 alpha, which affects the proteasomal degradation and again contributes to cell death. The fragments of mitochondrial DNA move to the cytoplasm where they activate the NLPR3 inflammasome, which is thought to be central to many of the features of MDS, including impaired hematopoiesis. ROS affect the VEGF promoter through HIF1 alpha, resulting in cell quiescence. And we also have the TNF receptor contributing to ROS, which causes widespread decrease in phosphatase activity. So there's a widespread increase in kinase activity throughout the cell, which alters cell signaling. One of the kinases with increased activity is ICAPA-B kinase, which is responsible for, sequestering NF-kappa B in the cytoplasm or not. So if we undergo proteasomal degradation, NF-kappa B goes to the nucleus where it causes things to happen. And we also have alteration in some of the cell surface molecules, altering their ability to bind to the mesenchymal stromal cell and receive, signals that support their survival. So, shifting gears, I know I'm going pretty quickly, but we're coming up to the end. So cardiac disease has long been recognized to be a leading cause of non-leukemic death in MDS patients. So the biggest slice of the pie is MDS and AML, and the second biggest slice is cardiac. So this is from a U.S. Medicare registry, and you can see that cardiac events are increased in transfused MDS patients compared to non-transfused. This is iron overload in the cardiomyocyte, so lots of the same things happening. But here you actually have 3 receptors that take up NTBI in an unregulated manner. And of course, you get loss and the damage to the mitochondrial DNA. So a couple of differences between cardiomyocytes and other cells. So first of all, they're very mitochondria rich. So if you're damaging the mitochondrial DNA, that's a problem. But the other thing is, what proteins do we have in cardiomyocytes? We have myofibrils. So if you're damaging the myofibrils, that's a big deal too. So that could certainly lead to an increased incidence of clinical cardiac events in MDS. This is an electron micrograph of a cardiomyocyte, and you can see it's nice and orderly. There's the nucleus, the mitochondria, the myofibrils look nice and organized. And this picture on the right is from beta thalam major with cardiac iron overload. And I think you can appreciate which you would prefer your cardiac cells to look like. So this was my pandemic project. I'd actually been working on it for many years, but was having trouble sort of taking that vast amount of information and making it digestible. And so this very talented student who has actually applied to the MD PhD program here at UBC helped me with the diagrams, which otherwise might have taken me a century. And this was published recently as a review. So I told you that it's not easy to measure LPI in a clinical lab. What we do know is LPI appear at a transferrin saturation over 80%, which of course we measure all the time. So we turned to the Canadian MDS registry and we looked at transferrin saturation in our MDS patients. So there were 718 patients, and sure enough, those with a TSAT that was consistently over 80% had inferior survival compared to those with a lower TSAT. And more interestingly, there was also a lower cardiac death-free survival than those with a lower TSAT. So, I'm always more comfortable once my patients have a transferrin saturation less than 80%. I think in the interest of time that I will skip through these quite quickly. It's just showing us that you can actually inhibit one of the NTBI channels in the cardiomyocyte using calcium channel blockers. And I'm coming close to the end. What I'm working on now is looking at what information there is in the literature on an interaction between iron overload, reactive oxygen species, and the specific MDS mutations. And this is where they act in the progression of MDS. So this is with Wendy Davis's help. And so you get your mutations, genomic instability, increasing clones, you have the altered merostroma, the inflammatory milia, and clonal evolution, and so on. So that's coming soon. So these are general comments on iron overload from the internet. There's a couple of very interesting articles. One's called Iron is the New Cholesterol, and it talks about how iron is central to many processes and disorders. And an abbreviated quote such as the Faustian bargain has been struck by life on this planet. Oxygen and iron are essential for energy production, but may also conspire to destroy the delicate order of our cells. Life was designed to exist at the very interface between iron sufficiency and deficiency. And even more interesting, iron is an ancient signaling molecule. It's not really a molecule, it's an atom, but whatever. So it talks about how iron was involved in signaling billions of years before the existence of ATP, which we're used to thinking about as the powerhouse of the cell. Environmental conditions and porous hydrothermal vents where heat and mineral-laden seawater spews from cracks in the ocean crust created a gradient and positively charged protons that serve as a battery to fuel the creation of organic molecules and protocells. So here we have the heated mineral-laden water coming out from the ocean crust, setting up a gradient, and that allowed the formation of organic molecules such as proteins, lipids, and nucleic acids. And so, without iron, we might not have life on this planet. So I think it's pretty important. This is from the Thalassemia International Federation, calm and chelate, and I would alter that to reduce transfusion requirements. So significant advances have been made in the understanding of MDS cellular biology. This has led to new classification systems. For several years, these advances have not translated to lots of new treatments, though we now have luspatercept and oral decitabine. Incorporation of somatic mutations into the IPSSM have refined prognostication. Further refinements in prognosis are expected with future advances, and the MDS clear path has been updated to reflect progress in MDS, and the MDS's iron road is available. We were designated an International MDS Foundation Center for Excellence a few years ago. And I also wanted to tell you that new at BC Cancer Agency in the last year, there's now a myeloid tumor group, of which Linda Foltz is the head. So we are kind of working together to get as organized in myeloid disorders as the lymphoma tumor group is in lymphoid disorders. And the other part of that is we just completed our first myeloid fellowship. So Wendy Davis worked with us for a few months doing MDS with me and MPN with Linda. And that was, really very rewarding for all of us. And Wendy's actually starting on staff on June 1st. And so I told you that I would tell you about the Canadian Consortium on NDS. So we do analyses like the ones I showed you. We have every 2 years, we have a Canadian conference on MDS, which the most recent one before the pandemic was in September 2019 here in Vancouver. I was volunteered to organize that. And then the other exciting news is that I have been approached about hosting the International Society for MDS conference here in 2027. This is a 2-yearly conference. It's usually in Europe. And so it may be coming soon to Vancouver. We've just kind of submitted a bid. So I did tell you about this. So we do have regular myeloid conferences. We're planning to set up a myeloid tumor database, and we hope to do future myeloid fellowships. And I told you about the CCMDS. And so I know I haven't left a lot of time for questions, but I'm happy to take questions by email or, chatting on the wards or whatever. And I will see if I can get back to the participants and see you guys and see who has their hand up or if there's just a stunned silence.
Thanks very much, Dr. Leitch. That was a very beautiful, comprehensive presentation. And I've asked people to step forward if they have any questions or put them in the chat box. Are there any questions by the Zoom participants this time? I just want to clarify that the residents are all the way in Whistler. So that's why you're seeing a lot of us and not many residents on the Zoom call today. I had a question.
Let's get to hear about this when I'm on service.
That was really nice in terms of the MDS clear path. And my question was, you mentioned that it obviously is open to all physicians. In terms of ordering the genetic studies, like the PCR of all the different mutations, that doesn't require hematology's consultation. It can be just done. Any physician can order the workup that's on the MDS clear path?
Yes, they can. So it is done on the bone marrow. So if you're comfortable ordering the bone marrow, which, a lot of you guys are. And so it's just a requisition on the BC Cancer website. So if you just go to their search box and type in CGL for Cancer Genetics Lab, it'll take you to the myeloid rec, and then you can just fill that out and the indication, and that's how it'll get done. What will happen is they will put it on hold until the cytogenetic analysis is available. And so then once that's available, then you, submit that form with the bone marrow biopsy report and also the cytogenetic analysis, and then they'll activate it. And they keep it for 6 months. So that, if you decide you want to do it later for any reason, you have up to 6 months to do it.
Oh, that's good to know. In terms of sometimes we get phone calls from remote places within BC, and so it's important for us to be aware of those pathways.
Yeah, for sure.
And I don't know if there is anyone else who wants to ask any questions. My other question was that was very fascinating around the effect of iron on just it seems like everywhere within the cells. From the Fenton reaction, I guess maybe I'm mistaken, but you also in your earlier slide showed the contribution of iron in terms of methylation. And has there been any studies that have looked at the methylation level in patients that have not had any chelation done? And is there a difference in DNA methylation?
That would be absolutely fascinating to do. So I'm not aware of any studies, but, I will definitely bring that to my, research colleagues like the woman that's doing the, studies on the epigenetics, but there's also a fantastic preclinical researcher in New York called Francesca Vinci, who does all sorts of studies with iron in the preclinical setting. So I was starting with kind of the, what's in the literature and sort of planning to take it from there. But I think that would be very, very interesting.
For sure.
Yeah.
Questions from the audience at this time? If there are none, Dr. Heather's email address is there, so any further question can be directed to her. I just would like to thank you for your very comprehensive presentation and for your time today. Really appreciate that update on MDS. And in addition to that, our next week's presentation would be on May the 25th. And our Division of Rheumatology will be presenting, Dr. Jennifer Reynolds will be presenting next week. So if there are no further questions, I'd like to thank you again for your presentation and wish everybody a really nice afternoon to enjoy the sun. Thank you, everybody.
Thanks, everyone.
Thank you.